YouTube and
You're getting some text, Dr. Manpreet Singh.
Yes, I see that. Thank you so much. Good to see you all virtually.
we're live on YouTube. Oh, there he is.
Good evening, everybody.
Good evening.
Hey.
Okay. The people are still joining in, but good evening, everybody. And we'll start in just about a couple of minutes. And the people are still coming in. And maybe it's 7:01 right now, so maybe at 7:03 we can get started. I see more people joining in right now.
You guys meet once a month, once a quarter?
Yeah, we meet every month, except in the summer. We don't have a meeting in the summer, and then in December.
And this is a Santa Clara chapter of NAMI?
Yes,
Yeah.
that's correct.
So you guys go from like Palo Alto down to Morgan Hill or
Yep.
Gilroy or something?
Gilroy, yeah.
Huge, huge.
All right. So let's get started. Good evening, everyone, and thank you so much for joining us tonight. My name is Rovina Nimbalkar, and I'm the Executive Director of NAMI Santa Clara County. Before we begin the program, I'm just going to go over some of the NAMI Santa Clara County updates. So all our programs have been virtual since March of 2020. It seems like a very long time. We're in 2022 right now. Our warm line is up and running from 10 a.m. to 6 p.m. Monday through Friday via phone as well as email. We do have after-hour family support, which is available on evenings and weekends. Support groups are all listed on our website, which is www.namisantaclara.org and offered over Zoom. All educational classes such as family to family, familiar to familiar, persona to persona, peer to peer, provider education. These are all over Zoom as well. And you can contact our warm line number, which is 408-453-0400 and select option 1 for further details. But just a little bit of information, like I do know information about a few education programs like our peer-to-peer program, family-to-family program is starting around mid-January, and the provider class is starting January 14th. The NAMI Basics program is an on-demand, and it's on our website, and you can take it at your own pace. Similarly, even the home front, which is online as well. The FaithNet trainings are on Thursdays, I think last Thursdays of the month. The community peer program has been continuing to match the hospitals as well as self-referrals. Also, I do encourage to check our website. We update our blog section with new articles written by Maureen Milo. NAMI Walks Your Way Silicon Valley was on October 9th, and we just closed the fundraiser, which was in December, and we're really excited to announce that we raised about $280,000. So I would like to thank all the team captains, participants, sponsors, and all the community supporters to participate in the walk and support us during this difficult times. Our walk for this year, we haven't finalized a date, but most likely it's going to be in October, and we're hoping that we can do it in person. I'm going to give some other updates. So today, the Santa Clara County Board of Supervisors discussed a referral from Supervisor Susan Ellenberg and Supervisor Otto Lee of declaring mental health crisis and substance abuse a public health crisis in Santa Clara County. And we would like to congratulate Supervisor Ellenberg and Supervisor Lee on getting unanimous approval for the referral. So we're really excited about this. The other update I have is Luisa Perez passed away on December 30th. She dedicated over 50 years of her life educating in the community, in particularly the Latino community, about mental health. In the early 1990s, she took the family-to-family class and attended support groups, and soon began advocating for classes in Spanish. Luisa received many awards for her work. There will be a viewing and rosary for Luisa on Wednesday, January 12th, followed by a service on Thursday, January 13th at Darling and Fisher Campbell Memorial Chapel in Campbell. So now, up to my updates, I am going to invite Bev Lozop, who is the co-president of the board at NAMI Santa Clara County. Bev, over to you.
Okay, thank you. As Rovina indicated, I'm Beverly Lozoff, and our board every year for the last 15 years. Is everyone hearing that? Okay. Every year for the last 15, our board has presented a Community Merit Award to honor an individual, a group, or an organization that has made a significant gain or improvement in the quality of life for people with mental health conditions. This year, we have chosen to honor Stanford Mood Disorders Education Day for their dedication and commitment over the course of 17 years to bringing the latest research and information to the community free of charge. Even the pandemic has not stopped them from putting on this great day. To accept the award, we have the co-directors of Mood Disorders Education Day, Dr. Alan Schatzberg and Dr. Manpreet Singh. But before we introduce them, I would like to introduce Sarah Prabhu, NAMI Santa Clara County's Warmline Help Desk Manager, who is going to share the life-changing difference Mood Disorders Education Day had for her family. Sarah?
Thank you, Bev. Good evening, everyone. My name is Sarah Prabhu, and as Bev introduced me, I am the Warmline Help Desk Manager at NAMI Santa Clara County. When my children were first diagnosed with mental illness, like any parent, I was on a quest to find answers. My quest led me to Stanford's Bipolar Education Day, now called Stanford Mood Disorder Education Day. That day changed the course of my family's journey. At this event, I heard for the first time that it is possible to change the outcome of mood disorder through family-focused therapy. It is also at this event I first met NAMI volunteers and learned about NAMI's education classes. In addition to gaining information on the latest advances in mental health treatment in a simple language, this event also provided opportunity for families to interact with experts in the field. These talks and interactions gave me and my husband hope and enabled us to make informed decisions for our children's treatment. Today, my children are successful young adults with passion for mental health advocacy. Their wellness and recovery has enabled me to come and give back to the community through NAMI Warmline. With deep gratitude for their outstanding service to the community, we present our Community Merit Award to Stanford Mood Disorder Education Day. I invite Dr. Manpreet Singh and Dr. Alan Schatzberg, co-directors, to say a few words and accept the awards. Dr. Manpreet, I give you, and Dr. Alan, we give you the floor.
Wow, I'm blown away, Sarah, and I'm so touched by this amazing award and recognition. We try very hard to do exactly what you described in terms of your experience. And the pandemic made it a little bit more creative for us to figure out how to deliver on our promise to the community. And we are really continued to feel a strong sense of commitment to serving and educating our community, and also learning from our community on how we can do better to advance science in the area of mood disorders. So thank you very, very much. It's been now 17 years, we're going on 18, and continuing to go strong. And it's really in large part thanks to you all for your commitment and your dedication and your amazing participation. Without you, I think we couldn't do this. And so we share this award with you. Alan?
Yeah, Frank, it was very touching being recognized by all of you folks for the efforts that Manpreet and I and the rest of the faculty put in every year to provide an educational program for the community. You know, education gives you ideas and tells you what's happening and what people are working on, but also education gives people hope. You know, hope that there are people interested in patients with particular disorders, and families who have loved ones suffering from a disorder, that there are folks working on developing newer, better, more rapid treatments. And I think that's really what we try to provide. Terry Ketter started it. We've continued it. It's become a tradition, and hopefully it will continue, you know, well beyond for another, 15, 17 or more years. We're very committed to trying to educate not only families and the public and patients about mood disorders, but also providers. We've, the last couple of years, done a program with the McLean Hospital folks, part of Harvard Medical School, about suicide and suicide prevention. Mainly for professionals. This last year, a virtual program that had over 1,800 providers attending around the country. So education and informing both the public and the professionals is essential if we're going to make progress. And we all, Manpreet and I, really want to thank you, not only for the award, but for all you do on behalf of those who still suffer from problems with psychiatric disorders.
Thank you so much, Dr. Singh, and thank you so much, Dr. Schatzberg, for your contribution and everything that you've done. We're really, really fortunate to have like some people like you in the community. Moving forward, I think we're going to go ahead with our general meeting presentation.
Okay, take care, everyone.
Yeah.
We'll be in person, so hopefully.
Yes.
Hopefully.
But we'll always be connected.
All right. Take care, everyone. Bye-bye.
Bye-bye.
Thank you. Okay. So moving forward, our topic for tonight is how the brain can change with family-focused therapy in youth at high risk for bipolar disorder. And our presenter is Dr. Manpreet Singh. Dr. Singh is an associate professor of psychiatry and behavioral sciences at Stanford University of Medicine. She's also director of the Pediatric Mood Disorders Program and director of the Pediatric Emotion and Resilience Lab. Dr. Singh earned her MD at Michigan State University and her MS at University of Michigan. She completed her combined residency training in pediatric psychiatry and child adolescent psychiatry at Cincinnati Children's Hospital Medical Center. After 2 years of T32 postdoctoral and training at Stanford Center of Interdisciplinary Brain Sciences Research, she joined the faculty at Stanford in 2009. I invite Dr. Singh to do the presentation. And I also want everyone to let everyone know that if you do have any questions, please feel free to post them in the Q&A section here below. And at the end of the presentation, we will ask other question and answers. Over to you, Dr. Singh.
Thank you so much for the kind introduction and for providing a little bit of a capstone on how long I've been at Stanford. It has enabled me to do a lot of very cool things. And probably one of the highlights of my career at Stanford certainly has been Mood Disorders Education Day. You all taught me a lot, not just about what I should focus my science on, but also on how to communicate effectively about that science. And so my hope tonight is to give you a little bit more of an elaboration on the promise of family-focused therapy and the evidence or science behind why we think it works, and invite you to have a dialogue with me. So I'll try my very best to keep the comments and the educational component limited so that I can spend more time learning from you and hearing your experiences. See if we can get this going. These are my conflicts of interest, mostly focused on research support. I won't promote any healthcare products as goods during my presentation. My focus today is going to be to discuss the evidence for family-focused therapy for individuals with or at risk for bipolar disorder. I'd like to give you some more context, particularly not just on symptom and functioning, but also on brain imaging assessments that we've done now before and after treatment that helps us understand how the brain changes potentially as a result of family-focused therapy and how we're conceptualizing that. And then I'd like to conclude with a partnership, as usual, to help me consider and continue to think about what are the unmet needs that we need to continue to serve. So as we all know, bipolar disorder has a lifelong impact. It starts early, and for most adults who have bipolar disorders, the onset occurs in childhood or adolescence. It's a chronic condition, so it starts when it starts early. In particular, it's associated with poorer long-term prognosis as well as increased risk for suicide compared with a later onset. It recurs, so it isn't just a single episode, one and done, but often comes back. And we've noticed that the frequency or the prevalence of it has increased even in younger and younger populations. And it's complicated. It's a condition that runs with other things. And so diagnosis can be often difficult to do and potentially delayed for very, very long periods of time because it's tricky to make a diagnosis if you don't have the right tools or information. Some factors that contribute to the early development of bipolar disorder are environmental stress, family and genetics, as well as inflammatory processes. Indeed, early symptoms can in themselves be factors that contribute. And what we think is happening is that the brain is very, very vulnerable or susceptible to lots and lots of inputs from the environment and from all of these factors. And what comes out is somewhat of a readout that we can see clinically, emotion dysregulation, possibly cognitive impairment, but interpersonal problems like psychosocial dysfunction, relationships that are significantly impacted by these symptoms play a major role in why people come to me in clinic and why episodes potentially develop, are triggered, and potentially recur. But that's just part of the story. There's also a very beautiful and very interesting thing that we've also appreciated that the brain does that remodels, and it almost protects itself from harm. And so when we partner with patients to try to come up with solutions, treatments that hopefully delay the onset, prevent the recurrence of episodes, the idea and the science behind that is that can we activate the brain to protect itself? Kind of like a vaccine, kind of like a medication, but it's not just about chemical imbalance at this point. We understand that the brain is very complex, and in our efforts to understand the various relationships among the different regions of the brain and how they might be interacting to make that regulation possible, we're trying ever so hard to continue to iterate towards better treatments. And we also appreciate that treatment in it itself has an impact on brain development. But do we know for sure whether medication has a lifelong preventative effect? Does psychotherapy have a lifelong preventative effect? Now we're beginning to do the longitudinal follow-ups and be able to make the case that indeed early intervention and prevention, as well as treatment, timely treatment, can be a major a source of hope for most patients who live with this condition, with the idea being episode prevention. There are some more assumptions that we have about the experience of bipolar disorder, particularly within the environment. The course of bipolar disorder, the ways in which it continues over the course of the lifespan, is strongly affected by the family context. If there's a support system in place, we notice that the trajectory or the prognosis seems to be better. Treatment, especially treatments that are involved in harnessing that social support, are a vital part of our effort to stabilize symptoms when they occur and reduce recurrences. And family interventions that are started or initiated early in childhood or adolescence improves the long-term trajectory of the disorder. And we have some early findings that really bring some facts or evidence to this assertion. So you can imagine this picture may be a familiar one, particularly in the context of an episode. But one of the areas of research that David Miklowitz, who has dedicated most of his career in contributing, is the idea that the family environment is chaotic potentially in the context of very serious mental illness, and particularly in bipolar disorder. And family member attitudes towards each other are very evident and manifest very commonly even in our offices. What do we see? We hear critical comments very commonly. Does she even realize that her crying keeps the rest of us awake at night? I resent her poor me attitude. Or even hostility. The problem is that when it comes down to it, I dislike the person he is. It's almost as if the person he is unable to be disentangled from the behavior that is unpleasant. And then there's a lot of emotional over-involvement. I don't invite people over because my son doesn't like it. And so there's just a lot of inherent desire for protection, but then that might in and of itself create some problems for social development down the line. So the criticisms, the hostility, the emotional over-involvement is what we call expressed emotion. Emotion is certainly expressive, but overexpression is really what this construct is alluding to. And it turns out that family-focused therapy might even be involved in moderating that, or directly targeting that expressed emotion aspect of what goes on in the family dynamic during bipolar episodes. And of course, homework is probably front and center for some of you who are online joining me right now, while also trying to maybe juggle parenting. Indeed, I had to do that just before I logged in with my 3 children. Math homework makes him depressed, so I do all the problems for him. Well, if you do all the problems for your kid, I'm never going to learn math themselves. So there's this over-involvement that potentially plays a role, and the goals in therapy then become empowering the child and the parents to work together to solve these challenges together in a more constructive way. So just to give you an idea of how expressed emotion might play out in terms of relapse, it turns out that if you have a high degree of family expressed emotion, then your likelihood of relapse is very, very high. And when you don't have as much expressed emotion, it's not as high, and you don't see as much of an impact on relapse. So this kind of makes sense as a potential trigger in the family dynamic. Pair that with a family history of bipolar disorder, where we see that when you observe over time the course of bipolar symptomatology, starting from maybe subthreshold symptoms where you're not quite meeting criteria for bipolar disorder, but you've got some stuff bubbling. If you follow those kids, especially over a course of now 10, 15 years, there's a group in Pittsburgh that's been following these kids and has found that the kids who had a bipolar family history were much more likely to convert to bipolar 1 or 2 disorder compared to those without a family history. So there's an independent risk factor there. And so then we have to wonder, we all have good days and bad days. These are my kids at a younger age, and I know you've seen these pictures before over the years. I like to share them because I like to illustrate that we all have our good days and bad days. And it's not to say that that in itself is abnormal or bad. We want to recognize that that's the case. But we're using a family history model to help us enrich our understanding of what uniquely happens in the environment when maybe bipolar disorder plays a role. And one of the things that we started, my journey I started with was not to necessarily start with kids who had already developed symptoms, but to look at kids who were actually healthy, didn't have any symptoms at all. And the only difference between them and another kid on the street was that they had a bipolar parent. And I looked at their brains and I found that even in a state of health, brain connectivity patterns were different than kids who didn't have a family member with bipolar disorder. And what was also very interesting was that the more disconnected their networks, the more family environment chaos was evident or reported. So chaotic family environments clearly seem to be having or playing a role in brain function and possibly even brain development. So that got me thinking that even before the onset of symptoms, there's a need for intervention. What can we do to help? And are there ways to maybe even prevent the onset of bipolar disorder altogether? Are these kids possibly showing brain network changes or differences compared to healthy kids that don't have any family members with bipolar disorder? Signs of resilience or compensatory circuit changes that might actually be trying to keep symptoms at bay? Well, that got me thinking, well, what's resilience? How can we understand it? And how can we potentially use it to help people keep symptoms and episodes at bay? Resilience has been generally conceptualized in the trauma and stress world because it's considered a dynamic process, but an ability specifically to successfully to stress, adversity, threat, or trauma. And it's considered to be on a continuum and can be cultivated with the potential to change across the lifespan. It's no news to any of you that bipolar disorder also is associated with significant trauma. And many people who experience bipolar symptoms have not only been victims of abuse, but potentially have been in family environments that have continued to struggle with this issue. So this model made sense to me to consider in the context of a bipolar family. But it also gave me an opportunity to wax a little bit about the glass is half full rather than half empty, because when families came to me in crisis and worry about what's going to happen to their kids, I could also be able to give them some hope and optimism that, hey, I don't know what's going to happen, but here are some things that we can do together to make sure that we keep your kid on the right path. And the principles are pretty, basic. I think we all know them. Sometimes they feel like cliches, keep a positive attitude, reframe your stressful thoughts, develop a moral compass, find a role model who's very resilient, face your fears, develop active coping skills like ones that you might practice in therapy, establish and nurture a supportive social network, prioritize your physical well-being, the importance of exercise, train your brain, whether it's through mindfulness or through other strategies, and play to your strengths, do what you're good at, and thrive. And so, there are aspects of living your best self and flourishing that come out or come across these concepts that it's very easy to forget, particularly in times of stress. And if we have the ability to engage with some of these principles, then we should. So we did a risk and resilience study starting with offspring of parents with bipolar disorder who were healthy, as well as offspring of parents with depression, to see how those differed, and compared them to kids without a family history of any psychiatric conditions. We've now followed them, many of these families, for some time now. I've had the privilege and honor to follow these families over a course of a long-term follow-up. And an initial evaluation of the results are also very interesting and promising, and show fairly low rates of conversion to bipolar disorder. So there's your glass half full silver lining, to remind you that not everyone who has a bipolar parent is going to go on to develop bipolar disorder. And that follow-up is most likely to lead to a combination of probably initial episodes of depression or anxiety. And so those are the things that we intend to treat first. The other things that we've learned in the story about the brain networks is that it turns out that the kids who have more disconnected networks seem to have more trouble with making friendships and keeping them, and are much more likely in those contexts to also develop a mood or anxiety problem of some sort that might go on to become a mood disorder. So if we can find a way to help address the neural circuits that are particularly involved in emotion regulation early on, maybe we can put these kids on the right path. And it turns out that indeed there are aspects of those brains that of offspring of parents with bipolar disorder that are very, very resilient and compensating in many ways. And it turns out that the ones that are compensating are more pro-social, are more likely to make friendships and keep them, and are able to process emotions, happy emotions, sad emotions, angry emotions, in a way that enables them to do better and in terms of functioning, but also to lend a hand and to be helpful. So can we cultivate pro-social behaviors in some way to change the brain and then to change the outcome? And in our early years of evaluating this, we looked just at the global effects of psychotherapy broadly, whether you got just a manual to educate you about your symptoms, or you got a few sessions of family-focused therapy. Your brain seemed to, the offspring of parents with bipolar disorder who had some mood symptoms at this point seemed to do better. They had more executive regulation. Their ability to control or regulate their emotions improved, and with that improvement and that connectivity, the strengthening of the connectivity in regions of the brain that are so important for that, also paralleled improvement in mood outcomes, improved depression symptom severity, improved mania symptom severity. And so with that, we wanted to do a much, much more granular look to see, is it truly the case that family-focused therapy or any sort of therapy matters? Or is it just the function of talking to someone friendly every week that's causing this effect? So in order to study that systematically, we did a randomized controlled trial where we randomized people who had a parent or a sibling with bipolar disorder and were already experiencing some symptoms, to either education alone, where that's all they got was just a little bit of education about symptoms and how to manage symptoms, versus adding some training about pro-social behavior. And what we think are pro-social behaviors are when you're actively listening or communicating or giving positive and negative feedback, or collaborating to solve problems like homework and chores at home, and empowering your child rather than either doing it for them completely or maybe expressing a lot of strong feelings about their resistance to do it. So when you add pro-social behavior training to just the simple education, that becomes family-focused therapy. So when you randomize people to either education alone or family-focused therapy, we see very interesting results. The yellow line shows you what happens in family-focused therapy, and the gray line shows you what happens with just education alone. And this is over, if you can see on this axis, time from recovery to time to first mood episode in weeks. And so you can see this is 146 weeks. We followed these kids over a 4 to 5 year period. And what you'll notice here at the beginning of this graph is that the lines are overlapping, which means that there were no differences in the groups in the first few weeks of the treatment. This is actually when the therapy was administered. It was baseline, and it was about a 16-week or treatment, right? So 4 months of family-focused therapy, or you got 6 sessions of just education alone. And so in that time frame, don't see any differences in symptoms. But when you look out, years out, you begin to see the differences. This is really important because when you do a randomized controlled trial, very often what gets reported are the baseline symptoms and right after the last visit. Baseline, 8 weeks, change in symptoms. We dismiss studies as negative and just say, we're done as soon as that study ends. And very rarely now, only now are we beginning to look, well, what happens after the fact? Can we understand what happens after that last visit? And that to me is where the magic is. These weeks and years after this intervention is when we begin to see the impact of family-focused therapy compared to just education alone, where the time to relapse, to have another episode, particularly of depression, was much sooner for the enhanced care group compared to the family-focused therapy group. We need to do some more work to understand how this works and what is at play here, but it gives you some ideas about why we're so excited about family-focused therapy and its utility in families affected by bipolar disorder. Now let me tell you the story on the brain situation. In those same kids who had a family member with bipolar disorder and had themselves some mood symptoms, not bipolar disorder yet, just they were at risk for it because of the family history. Compare those kids' brains to brains of kids who don't have any family history or any psychiatric symptoms, and you see a predictable difference in brain connectivity patterns. It were very much like what we had seen back in 2015 and reported on, where, you know, even in asymptomatic kids, you saw this disconnectivity between areas of the brain that regulate emotion and areas of the brain that control emotional expression. And lo and behold, that difference showed up in this high-risk group as well. When you did family-focused therapy, that treatment, in fact, enhanced that connectivity to the point where the people who got the family-focused therapy actually had depression symptom improvement that correlated with that strengthening in connectivity. You didn't see that effect in the kids who got the education alone or in the healthy controls. So we think that this effect is very specific to the treatment. And so we've now figured out a way to change the brain so we can change the outcome. Well, what is the outcome? Well, we talk about pre-post, baseline, 8 weeks or several weeks or years out. But what we've discovered in our analyses of these data sets is that realize you've taught me, is that symptoms are one thing, but functioning, that's much, much more relevant and important. Quality of life, much, much more important. And so we've looked at the trajectories and we found that depending on the level of symptom severity, that it's absolutely true that different people are going to have different patterns. And because they're going to have different patterns of response, we need to do a better job of personalizing how to match them with the right treatments based on how we understand their functional trajectories are going to go. So we're not just looking at symptoms, we're also looking at functioning and quality of life. So how do we think that psychotherapy works? We think that it improves emotion regulation. It probably targets that expressed emotion and treats the system. it improves the quality of the family relationships as well as physical well-being, because it coaches you to get out there and do stuff together physically, like exercise. Interactive effect, we think that there's an interactive effect in the way that the family focused therapy encourages you to take your medications, keep a daily schedule. And most fascinating discovery, in my view, is the idea and the concept that family-focused therapy, making an improvement on the environment, actually changes the brain. And that, to us, is a very intriguing possibility that we're continuing to investigate further. Functioning and perhaps even training on pro-social behavior, like we think it's set out to do, is probably also playing a role in learning. And our goal is ultimately remission and prevention of relapse. And we use, obviously, a multimodal approach, medications in combination with educational intervention and psychotherapy to treat the system. But just to give you an idea, there are a number of strategies being employed in terms of helping the psychosocial environment of the bipolar family. And family-focused therapy currently has the strongest level of evidence, but you have other strategies that are being explored, including interpersonal and social rhythm therapy, as well as mindfulness-based cognitive therapy, with the appreciation, again, that not all roads lead to Rome and that different people might need different things. So kids may not be many adults, but mania can start in childhood or adolescence, and we should try to understand its origins better. And we might be able to potentially prevent mood disorders, including bipolar disorder, from lasting a lifetime if we start with early family-based psychosocial interventions. And the idea is to create a roadmap for the future. Our focus, our research is to discover biomarkers we can detect these symptoms early and specifically, maybe even preemptively intervene, like family-focused therapy for those detected to be at risk in pre-symptomatic stages. And of course, we're passionate about developing better treatments for people living with symptoms, so that that not only improve symptoms, but predict and track the outcomes that matter to patients the most. And that's my final takeaway, that early signs of neurofunctional change can be observed before symptom improvement or outcome. And we need more systematic studies that integrate this understanding of symptoms, brain changes, functioning in the long term, and their respective timelines, so that we can do better. And we all must remember that we are resilient. So knowing when to treat things, allowing adaptive mechanisms to kick in, is much worth pursuing. I'd like to acknowledge my village at Stanford. They're a wonderful group of people, and invite you to ask questions and also share thoughts and pearls and experiences. Thank you for your attention.
So much, Dr. Singh. And everyone feel free to ask questions in the Q&A section, and I'll be happy to ask those questions to Dr. Singh. I do see one question right now in the Q&A section. It says, the question is there evidence to suggest a link to substance use in utero?
In utero, right. So in the pregnant womb, can substance use have an impact? And there are studies that do suggest that certain kinds of drugs can have a negative impact on a developing baby in utero. And so happy to point you to literature on that, but that's pretty well known. And the other concern, not just from the perspective of developmental changes that can occur, but when the baby is delivered, oftentimes we see, and I remember as a pediatric resident in Cincinnati, I used to see a few babies who were experiencing withdrawal because they became dependent on the drug that the mom used. And so that does happen. And then, oftentimes there's protocols in place in nurseries and neonatal intensive care units to help the baby wean off of the drug as well, and to make sure that they have a gentle start to their lives. And substance use is a challenge. But, again, in context too of understanding and appreciating how life unfolds, it's another reason to if bipolar disorder is in the mix, managing symptoms and maintaining not just euthymic mood, but also sobriety is so important. So oftentimes risky behaviors end up becoming part and parcel of the story of an episode. And so, medical interventions end up being kind of doing a little bit of a wild goose chase. So this is why prevention can be so valuable, to prevent these kinds of potential challenges that have now become even more complicated with the pandemic. So
Yeah.
all the more reason to reach out and to be connected and to make sure that you keep all of your preventative strategies in place. How can one access family-focused therapy? This is a great question, and this is something that is such a deeply passionate area for me, because access has been, it's not a new thing. It isn't a pandemic problem. It has been a problem for a very, very long time. We have limited numbers of people who have learned to do these treatments and can administer them. There is a book that Dr. Miklowitz has published on family-focused therapy that you can go Google. That manual is a kind of a textbook for those who want to learn to implement the treatment. And for years, I've said to you, we want this to be more implemented in the community. We want this to be available, accessible to everyone, because it's so looks like it's so promising. So Dr. Miklowitz, good news, is working on a digital therapeutic application of family-focused therapy, a mobile health delivery of this, if you will. But I will tell you, there's a little bit of difference between doing this in person versus doing it via telehealth or via a mobile app or a digital, virtual avatar kind of deal. And I think we have to understand what those differences are, so that we don't overpromise and underdeliver, and that people don't experience the natural disappointment that might occur from having something that they thought would be one way versus another. So we have some work to do to really make sure not only that it's disseminable, acceptable, available, but that we also understand the science behind what it is that's working. So another thing that we're working on to help this be more accessible is to figure out the key ingredients. What are the things that are actually making a difference in therapy, and what are they targeting, so that not only could we understand how the treatment is working better, but also to do a better job mixing and matching. So for those people who need more problem-solving help or skill development, communications, we focus on that more. And so those kinds of strategies are not very well go in a clinical trial, where you kind of have to stick to what you're going to do just the way you're going to do it. And so we that's how we've been able to get the data to date. But it's obvious to us that not everyone would benefit from the same kind of treatment. And so those adaptations require more clinicians who are trained in this. So that, as Schatzberg said earlier, is also something we're very committed to. We spend much time educating therapists around the world on how to do these interventions. Next question I see here is, do you have any resources for families to access? Again, so same kind of question. And the way that I would say more specific response to how you access family-focused therapy in the current state of affairs is to go to a center, an academic center, if you have access to one, and specifically ask for that modality. I would like to get family-focused therapy, and see if there are clinicians who can administer them. Other clinicians out there who are doing this may actually be able to pick it up fairly quickly, and so if they've done family therapies and different kinds of modalities, it's pretty easy to pick it up and to learn how to implement it into your practice. which is why those manuals are available publicly. And so asking for it for your existing therapist or psychiatrist or treatment provider can be a really great place to start. So you start with your practitioner and say, hey, I've read about, or I heard Dr. Singh talking about family-focused therapy. We'd love to do something like that. How can we get started? The next step, I imagine, would be getting to a family therapist, and then the family therapist could then adapt that treatment in that way. So that's sort of how I see that flow, that workflow going. If you're looking to in a digital app, I don't think that's available yet, but there are definitely people trying to develop interventions in the family system, and telehealth has changed again the way that we might be able to make more accessible things that have not been possible. Like before, people had to drive 60 miles or more to come to Stanford to get family first therapy, where Pivot has necessarily required some practitioners to do it virtually. And as I said, there's pitfalls to that. It's different. And it's hard I'll just give you the perspective as a clinician, it's hard for me to do family work when families are in their native environment. Great to see, but sometimes hard to provide opportunities for skill development when we're not in the room together. So these are things that I think we have to figure out how to adapt towards, and figure out, again, maybe some families are much more amenable to doing via telehealth versus in person. And those innovations are happening right now, because guess what? We don't have time to think about how to do this anymore. We're having to do it on the fly. So my hope is that we'll have some more data to be able to share with you at the 18th annual Education Day on how we're doing in terms of making progress in implementing these treatments.
Thank you so much, Dr. Singh. So I know we have a hard stop at 8 o'clock. There were some other questions in the chat section, and I'm happy to go over them if you'd like. I think there's a question that says, how do you ensure treatment fidelity for families receiving family-focused therapy?
Yeah, so that's, I think, one of the major challenges is that the manual kind of tries to keep you honest, right? This is how you know you're doing what the treatment is asking you to do, but it's very easy to go off track. And I don't think that that's a criticism. Let's give ourselves all some grace. It's not hard to imagine that sometimes we all find ourselves coming off track because that's what the moment needs. So I have a lot of compassion for that. At the same time, there are some specific goals to meet in the treatment that fidelity addresses. So the idea is, how well are you faithful to doing the treatment exactly the way it's written? And I think the ways that you can be an empowered caregiver, participant in that process is read up about the treatments. And so I tell you, there's 3 components. There's education, so you should be getting at least 4 weeks of learning about mood symptoms and how they manifest in each of the family members. And so understanding how those mood symptoms manifest and charting moods is kind of part of that 4-week process. And the second 4 weeks, or 4 to 6 weeks, is communication skills development. So there's specific exercises on how you communicate with each other, and the specific things that you work on are active listening. So I'm not doing a very good job of active listening right now because I'm just talking to you. I ought to be listening, but I think the webinar format is the way it is. But spending a lot of time listening, as much as you are perhaps contributing to knowledge transfer and teaching and learning and regulating together, is very important. Giving feedback, whether it's positive or negative, also a communication skill that all benefit from working on. Not, this isn't something specific or unique to bipolar disorder. All of us might benefit from that. So, and then problem solving is actually probably something very intuitive to all of you. Is like you walk into the office and you say, "Doc, help me get my kid, to take out the dishes from the dishwasher. I have to ask him every single night." Well, how a practitioner ought to do that, the fidelity of the treatment would be to actually have the family solve that problem rather than having someone like me come in and solve the problem for you. That sort of gives you an idea of what you should expect, and then you can use the literature to help. The bipolar. I know the question about the book, so I'm gonna try to see if I can find it and put it in the chat. I think yes, bipolar disorder family focused treatment approach. Exactly right, Elizabeth. So hopefully that'll catch your eye. And even if you Google Dr. Milowitz, he's got a number of books out, and they're very accessible for anyone to read. And the beauty of it too is that you don't have to decode this yourself. Go to the doctor. That's why we're here. I mean, at least that's why I believe I'm here. It's partnership. And so, being an educated consumer enables you to know what you can expect from your practitioner and also ask of your practitioner. So it's really helpful for them to hear feedback from you that, hey, doc, this isn't working so much for me. I kind of need this. and that's helpful feedback for all of us. And I'm so glad, Catherine, great to see that you're advocating and enabling. The giving back is just such an important kind of pro-social behavior, I will say. It really is something that we all, I think, as humans have a natural inclination toward, to helping each other and supporting each other. And especially in these times when loneliness can become so central to our experience, any way you can reach out to each other is extremely important. It could prevent suicide. It could save a life. And so I really appreciate and honor all of those folks working so hard on front lines and crisis settings, but also in your own homes. Anytime you can give an invitation is very, very helpful. How can you be pro-social but not enable negative or harmful behaviors and cognitions? Great question. So this, I think, would be a great final question to end off on, although I see something from in the Q&A as well, but we'll try to see if we can get to it. What I want to say conceptually about being pro-social is that it doesn't mean that you're letting people off the hook. So there's a difference between being nice and being kind. Being nice is you say nice things, you kind of play it cool. Being kind is understanding what the other person needs and really working very hard to help them. Might even mean to empower them to help themselves. And so empowering them to help themselves might require some suspension of judgment. So you have to be a little nice. You can't just say, I'm criticizing you for this harmful negative behavior, shame, 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 shame. It might not get you very far. Why aren't you wearing a mask? Shame on you. It's not getting people very far. Shame each other. But you can imagine, I'd love to see us all work together. How can we bridge the divide? How can we work together for a common goal? What makes you tick? How can I help you? What does this mean to you? Maybe the question maybe it's not a statement or a declaration. Maybe it's a question that you ask. How can I help? And sometimes, again, there's a need for grace. I understand this is really hard. The choices we make in life are sometimes really hard, and sometimes we don't have any control over those choices. How can I help you regain control? Some thoughts, try them out and let me know if they work. And yes, there's definitely lots of resistance. People come kicking and screaming. And oftentimes therapy doesn't work very well when people are kicking and screaming and don't want to do family-focused therapy. You can't force it. But the way you have to probably engage with a process, even if you believe in it, is really finding ways to have others believe in it too. And some of that might require some discussion about what would it take, for you to participate in this collaborative treatment with me. And I will be, it is completely fair to say that when you've had negative interactions for a very long time, why in the world would you want to sit in a room with someone you can't stand being in a room with at home for a therapy visit, right? So that's why family therapy ends up becoming kind of a time sensitive and very, very strategic intervention. Sometimes you have to do some individual work so you can get to a place where you can do the family work. Sometimes the family work ends up opening up lots of possibilities for individual work. So these are things that are discoverable and very much in the domain of what you can discuss with your practitioner. So with that, I'm going to ask if I can beg your forgiveness, as I have 3 children who need to go to bed at this point. But I very much look forward to interacting with you all again. Please be compassionate, be kind to each other, and continue to do the wonderful things you're doing to inspire and to maybe just reduce loneliness just a little bit for anyone. Thank you.
Thank you so much, Dr. Singh, for joining us tonight. And we're really honored to have you here. And thank you for sharing all this information. And congratulations again for receiving the award on behalf of Stanford Mood Disorder Day. And hopefully we can meet in person soon. And, we don't have to deal with this whole online meetings and this pandemic will end soon. So thank you again once more and Happy New Year. And thank you everyone for joining us tonight. And we'll see you next month.
Thank you, everyone.
Bye.